Hi, Professor. I will be doing my final presentation today on myocarditis. So getting into it, what is myocarditis? It is a rare cardiovascular disease resulting in inflammation of the myocardium. The myocardium is the specialized muscle tissue of the heart that keeps the heart pumping blood. It does that by assisting in the contraction and relaxation of the cardiac walls so that blood can pass through the heart chambers. It also helps in conducting the electrical current through the tissues of the heart. And during myocarditis, the heart enlarges, which weakens its ability to effectively pump blood through the body, and it also affects the heart's electrical systems. This is a diagram of the layers of the heart wall. So if you were to cut out a small section of the heart, these would be the three main layers that you see. So that thin yellow layer on the outside is the epicardium, and then on the bottom, that thin blue layer is the endocardium, and then the large pink layer in the middle is the myocardium, which is mainly what's affected with myocarditis. So myocarditis is identified as the third leading cause of cardiovascular deaths in young athletes at about 6%, next to only coronary artery abnormalities at 17% and hypertrophic cardiomyopathy at 36%. And these statistics are from an academic journal called Myocarditis by Lori Blowett and Leslie Cooper. Getting more into what coronary artery abnormalities and hypertrophic cardiomyopathy are. So a coronary artery abnormality is basically exactly what it sounds like. It's an abnormality of the heart. It's just something in the heart is set up the way it's not supposed to be. So if you look at the bottom of the slide on the left hand, that left-hand picture, you can see the left is a normal heart. And you can see that the left coronary artery is coming out of the aorta, which is what it's supposed to do. It's what it would look like on a normal heart. And then on the right-hand side, you can see that you can see that the left coronary artery is now coming out of the pulmonary artery, which is not what it's supposed to look like. And then because of that, you can see at the bottom of the heart, it causes tissue death. And then getting into hypertrophic cardiomyopathy, it's a condition where a portion of the heart becomes thickened and enlarged, and that lessens its ability to pump blood through the body. So if you look at the bottom of the slide again, the right side picture, you can see that there's the normal heart. That you can see the right and left ventricle are labeled, and then the pink space that's in between the ventricles, that would be in a normal heart. The ventricles can expand and contract as much as they need to. And then on the right side, you can see a heart that's affected by hypertrophic cardiomyopathy, where that pink space is enlarged. And because of that, it puts extra pressure on the heart ventricles, and it affects the ability of the ventricles to expand and pump blood. And this is just a diagram of what myocarditis looks like. So like I said earlier, myocarditis is essentially just an inflammation of the heart muscle. So that bright red area represents the inflammation. And similar to cardio, or going back to hypertrophic cardiomyopathy, that pink area is inflamed. And then that's similar to what happens in myocarditis as well. There's the inflammation, and then that puts extra stress on the other parts of the heart. So who's at the greatest risk of developing myocarditis? This would be young adults, children, and infants, healthy young athletic types, affecting people mostly between the ages of puberty to their early 30s, and it also affects males twice as often as it does females. So it's kind of a disease that affects a group of people that you wouldn't really expect it to. I believe that most people would expect a heart condition like this to affect more of the elderly group of people, but it actually affects athletes and people that are in very good health. So this is a diagram showing the rates of myocarditis among age groups. And like I was saying, you can see that in early age groups, mostly between the ages of 16 and 30, the rates of myocarditis are very high. And then as a person ages, the rates drop down significantly. So some of the major symptoms of myocarditis, one of the scariest things about this disease is that it's very difficult, one of the scariest things about this disease is that a person may not display very many symptoms at all, and in many cases a person might actually be asymptomatic, meaning they won't show any symptoms, which really makes it a significant potential for a doctor to misdiagnose it, because the few symptoms that a person might show, a doctor might misidentify for symptoms of another disease such as a heart attack or a viral infection. And this information comes from the Myocarditis Foundation. And going on next, but if you were going to look at the symptoms, some of the most common ones include shortness of breath, especially after exercise or when lying down, fatigue, heart palpitations, which is a sensation or racing feeling of the heart, chest pain or pressure, which is angina, lightheadedness, swelling in the hands, legs, ankles, and feet, and also a sudden loss of consciousness. And this information also comes from the Myocarditis Foundation. So some of the major causes of myocarditis, so after doing research, I found pretty much the four major causes are viral infections, autoimmune diseases, hypersensitivity, and toxicity to chemicals and drugs. So getting into viral myocarditis, which is the most common cause of myocarditis, the viral family that's responsible for the most cases is the Enterovirus family. And within that family, you have the Coxsackievirus and the Adenovirus, which are the two viruses that make up the most cases. And then some of the other viruses that make up a smaller proportion of myocarditis cases include HCV, HIV, EBV, and CMV, the influenza virus, and also coronavirus, which I'll get into more at the end of the presentation. And then this information comes from an overview of the immune mechanisms of viral myocarditis by Ninad Lazarato and Jay Reddy. So getting into the enteroviruses. So the enteroviruses are among the most prevalent family of viruses in the world. They infect millions of people every year. The most famous enteroviruses are probably the polioviruses. The polioviruses were most prevalent in the late 80s and the early 90s, where they infected and they also crippled hundreds of thousands of children, making it one of the most feared viruses of the modern age. An enterovirus infection is usually significantly mild, but if it were to infect the central nervous system, it can cause serious illness. And that information is from Enteroviruses, The Famous Unknown by Laura Bubba. And then Coxsackievirus, more specifically the Coxsackie-B-virus, is one of the most common causes of viral myocarditis, making up 10 to 20% of all the cases. It's mostly diagnosed in young males. And when someone contracts the disease replicates in their gastrointestinal tract and in the spleen. And then after that, it travels into the heart where it causes damage, and usually has about a 2 to 10 day incubation period. And this information also comes from Enteroviruses, The Famous Unknown by Laura Bubba. So how is Coxsackievirus contracted and detected? It's mostly contracted from contaminated shared objects. So a good example of this would be public transportation, like handles on a bus or railings or seats or seat belts, things that many people throughout the day will touch that aren't cleaned periodically or very often. It can also be contracted through swimming pools that are underchlorinated or through contaminated ponds and other water supplies. And also, if someone were to have an open wound, you can contract the Coxsackievirus from an infection of that wound. And then it's detected through throat and rectal cultures, which are used to establish the diagnosis. And then pharyngeal swabs will be positive earlier in the disease than rectal swabs are. And a pharyngeal swab is a swab that goes by the pharynx, so in the back of the throat. A good example would be if anybody's ever been tested for COVID-19 recently, the deep nasal swabs that go up past the top of the nasal cavity, sort of like into the back of the throat. That would be an example of a pharyngeal swab. So the adenovirus are viruses responsible for a wide range of conditions, including respiratory disease, gastrointestinal disease, bladder inflammation. They're transmitted mostly through droplets when the patient sneezes or coughs, so a little bit different than the Coxsackievirus. But similar to the Coxsackievirus, you can catch the adenovirus through contact with contaminated objects, swimming pools that are underchlorinated, and other contaminated water sources. Unlike the Coxsackievirus, which makes the adenovirus a lot more dangerous, is that it can survive harsh environments for prolonged periods of time. There was one study that showed that it could survive up to 30 days on some plastic and metal surfaces. And then the adenovirus is mostly diagnosed through blood and stool samples. And autoimmune disease and myocarditis. So approximately 2/3 of AIDS patients who do receive antiretroviral therapy have signs of myocarditis postmortem. So this basically means when someone dies of the AIDS virus, they would have an autopsy done. During the autopsy, the doctor or whoever's conducting it would examine the patient's heart, and then they would see evidence of myocarditis in that person's heart. Antiretroviral, those are drugs that help prevent retroviral drugs. A retrovirus is a virus like the HIV virus that uses its DNA and genome to infect the nucleus of the host cells. So the HIV virus infects the body, the DNA of the HIV virus goes into the host cell, and then it reprograms the cell to become the HIV virus and then replicates from there. It occurs more frequently in uncontrolled HIV in later stages of the HIV infection, and even in patients with a control of the viral load, myocarditis can still occur. And like I said, the biopsy or the autopsy after the person's dead would confirm a diagnosis of myocarditis in HIV and AIDS patients. So toxic drug and induced myocarditis. So inflammation of the heart muscle resulting from drugs used illicitly or as part of a medical treatment. It's characterized by inflammation of myocytolysis, gradually resulting in the death of myocytes and replacement of fibrous tissue. So that's a little bit complicated of a bullet point. So basically what that's saying is the myocytolysis is a condition where the myocytes of the heart die. The heart is made up of cells called myocytes. Myocytolysis is the death of those cells and then the replacement of them by fibrous tissue. Fibrous tissue is essentially just scar tissue. So when the tissue dies, it's replaced over by scar tissue. The problem with scar tissue is that it can't expand and contract the same way that normal tissue does. So having an excess amount of fibrous tissue puts extra pressure and stress on the heart, which makes it harder to pump blood. Some of the drugs that are commonly associated with myocarditis are alcohol, cocaine, epinephrine, amphetamines, and dopamine. And this information comes from the Myocarditis Foundation. And then in this picture, you can see that on the left there's a healthy heart, and then on the right there's a heart that's been affected by someone who drinks alcohol heavily. And you can see that, especially along the top and the right side of the heart, it's starting to turn black a little bit, and that would be an example of that fibrous scar tissue that's starting to go over the heart. And hypersensitivity to myocarditis. This is one of the rarer forms of myocarditis. Like all other cases of myocarditis, it's an inflammation of the myocardium, but in this case, it's related to a drug allergy. The treatment consists obviously of discontinuation of the use of that drug. Some of the common drugs that are known to cause hypersensitivity to myocarditis are penicillin, antibiotics, and anti-seizure medication. And this information comes from Myocarditis Related to Drug Hypersensitivity by Charles Taliercio and Byron Olney. And so diagnosing myocarditis, there's a few common ways that doctors have been doing this over the years. One of the more common ones is electrocardiogram. So an electrocardiogram detects the activity of the heart by putting electrodes on the person's skin, and then the activity is recorded as waves that represent the electrical forces in the different parts of the heart. It's one of the most widely used screening tools. The sensitivity of an electrocardiogram for myocarditis is about 47%, so it's not super accurate, but it's accurate enough where doctors use it pretty consistently. The next way that doctors have been diagnosing myocarditis is with a chest x-ray. So a chest x-ray may show a cardiomegaly, which is an enlargement of the heart due to a chamber dilation or a pericardial effusion. A pericardial effusion is a buildup of fluid in the sacs that are around the heart. And then in addition to that, it may also find pulmonary venous congestion, which is a buildup of fluid in the lungs. And then the third way that myocarditis is being detected in patients is with an echocardiogram. It's useful for evaluating cardiac chamber size, wall thickness, systolic and diastolic functions. What I thought was interesting is that, so the echocardiogram itself can identify myocarditis, but it can't identify many other common heart problems. So basically the doctors will use the echocardiogram to rule out many other heart conditions, and then that would leave myocarditis and a few other less common heart conditions. And then this information about the few methods that doctors have been using to detect myocarditis comes from Diagnosis and Treatment of Viral Myocarditis by Jason Schultz and Anthony Hilliard. And these pictures on the bottom, the left side would be what a normal electrocardiogram looks like. The middle picture would be a chest x-ray, and then the right side would be an echocardiogram. So earlier in the presentation, I said I'd be talking about COVID-19 and myocarditis, which is what I'll talk about now. So it has a very strong relevance today. especially because many universities are attempting to go through with their college football seasons amidst the COVID-19 pandemic. And this has brought up a lot of concerns about the relation between COVID-19 and myocarditis and the long-term effect that athletes that were tested positive for COVID-19 may have down the road for developing myocarditis. So COVID-19 has been linked to myocarditis with higher frequency than other viruses, and myocarditis has been a growing concern over the last few weeks for the Power 5 conferences. And the Power 5 conferences are the 5 biggest conferences in college football. It includes the SEC, the Big 10, the Big 12, the ACC, and the Pac-12. Myocarditis has already been detected in at least 5 athletes in the Big 10. And like I was saying, the long-term effects of the disease have been intensely discussed among the school presidents, and chancellors, and commissioners, but it's unclear what the long-term effects are, so it's making a lot of schools very cautious about how viable their fall season may be. So Dr. Matthew Martinez, who's the director of sports cardiology for the Atlantic Health System, lead cardiologist for Major League Soccer. He's a team cardiologist for the Jets and a consultant for the National Basketball Players Association, so he's very involved in college and professional athletics. He's talked with physicians from the Power 5 schools, and together they've identified over a dozen athletes with post-COVID-19 myocardial injury, and Dr. Martinez estimates that the number of post-COVID-19 heart-related issues among college and professional athletes is to be close to about 5%, which is significant and definitely high enough where teams, both college and professional, need to strongly consider the safety of their players and how viable it is to have a sports season. So one of the biggest risk factors associated with myocarditis in athletes is that the inflammation, which can turn to scar tissue and puts the athlete at risk of irregular heartbeat, can be exacerbated by exercise, which athletes participate in frequently. This information comes from the Diagnosing and Sports Counseling of Athletes with Myocarditis, an academic journal by Christoph Granny. And then, so some specific examples of players. This is more on the extreme side. Players that have been in the news because they've had an extreme negative reaction to post-COVID-19 myocarditis. So the first example would be Brady Feeney. He's an offensive lineman at the University of Indiana. He received national attention over the last few weeks because he was a player in seemingly perfect health and great physical condition. And then he tested positive for COVID-19, and shortly after, he developed breathing issues. And then he spent multiple weeks in the hospital in the ER fighting for his life. Another example would be Cedric Williams, defensive lineman at the University of Houston. Cedric Williams didn't have as severe reaction as Feeney did, but he opted out of the 2020 college football season because of heart problems associated with his COVID-19 diagnosis. And then the last example would be the Boston Red Sox pitcher Eduardo Rodriguez. He was diagnosed with COVID-19, and then once he recovered, he was allowed to return to practice. But soon after he returned, he began developing breathing problems, and then after that, he was diagnosed with myocarditis. And since then, he is sitting out for the rest of the baseball season. So how schools are responding. So because of these extreme cases, a lot of schools have been prompted by the athletic directors and school committees to develop really extensive plans for how they're going to help their athletes get through these diseases and make sure that the athletes are tested and screened properly for these diseases. So the first example would be So it's a new consensus that many schools will use a cardiac MRI to detect myocarditis in their athletes, and it now has become an integral part in most plans to detect myocarditis. So the University of Washington, they came out with a 5-step athlete evaluation plan. The first step is to review the cardiovascular symptoms of the athletes who test positive for COVID-19. Step 2 is to give the athlete an electrocardiogram to measure their heart's electrical signals for abnormalities. Step 3 is to have a blood test for troponin. Troponin is a protein that's released by the blood during heart inflammation. So the idea here is that if a person has a myocarditis, their heart will be inflamed, they'll have troponin in their blood, and then the school will be able to detect it during the blood test. The 4th step is a heart ultrasound to measure structure and function, and then the 5th step is the cardiac MRI. Kansas State University, a bit of a different plan. So rather than testing athletes that are already on the campus, Kansas State is testing athletes before they come to campus. for COVID-19, and they're also blood testing them for antibodies to see if they've had COVID-19 prior. So they can also, and if they have had it prior, they can test them for myocarditis earlier in the process. And then those who have tested positive receive an electrocardiogram and a blood test for troponin as well, which is similar to the University of Washington plan. And then finally, the University of Virginia, the athletes are held out of participation for 3 weeks. They get a repeat physical exam, an electrocardiogram, and then they're slowly eased back into activity. This is my works cited, shows the academic journals and some of the other websites that I used. Thank you for your time listening to my presentation. I hope you enjoyed it and thought it was informative. Thank you for teaching the class, Professor, and I hope you have a great rest of your year. Thank you.